Welcome, everyone. Welcome. We have a large crowd for this webinar from all over the country. So please, if you want, you can put in chat where you're sitting, and you can see how much of the US we're covering. So it's 6 p.m. Eastern here in Massachusetts, where I sit. Welcome to Ask the Alzheimer's Expert. Okay, a conversation with Dr. Budson about normal aging and dementia. As you probably know, June is Alzheimer's and Brain Awareness Month, and AARP Massachusetts and the Alzheimer's Association of Massachusetts and New Hampshire are partnering to bring you tonight's program, as well as Brain Health Tuesdays at noon in June, all through June. So check those out as well. I'm Kara Cohen with AARP Massachusetts. So as you probably know as well, AARP maintains a deep focus on the health, financial security, and personal fulfillment of people 50 and over and their families. And you'll find that reflected in our offerings and resources and in our advocacy as well. We just wrapped up a month-long series for caregivers in May. And our 6 pillars of brain health was one of the topics we addressed. You can find that recording and all of our other past events at the AARP Massachusetts YouTube page. I encourage you to go there and maybe become a subscriber so you don't miss a thing. So to keep up with all that AARP is working on and offering, you can also go to aarp.org/local. Check out the AARP Brain Health Resource Center as well at aarp.org/brainhealth. Easy URLs, but I'll put them in chat afterwards. If you go to that one on brain health, you'll find lots of tips and tools and explainers on brain health. You can also learn more about the Global Council on Brain Health, which is convened by AARP. It's an independent collaborative of scientists, health professionals, scholars, and policy experts from around the world that are working in the areas of brain health related to human cognition. And they're really joining together to encourage action around this. And in fact, we've also convened Brain Health Action, which is another collaborative that we launched aimed at igniting a movement to change how we think about brain health. Many of us know someone living vitally into their 80s or 90s, yet people still think that cognitive disease is a normal part of aging. Our brains change as we age, but if we treat our brains and bodies well, we can do a lot to keep our minds healthy and strong. Brain Health Action is a multi-year, multifaceted initiative, energizing all of us to choose brain-healthy lifestyles. We're hoping to transform the current fatalistic narrative about dementia, around dementia, into a more action-oriented, constructive, and realistic one focused on building our brain health. Thank you. We want to move from hopelessness to hope and to reduce the stigma associated with cognitive decline and dementia. So again, please check out all of this and more by going to aarp.org/brainhealth. So now I'm going to introduce Nicole McKern, Director of Programs and Services at the Alzheimer's Association, Massachusetts, New Hampshire chapter. And Nicole will be moderating tonight's program. Over to you, Nicole.
Thank you so much, Kara. And thank you so much to AARP for co-hosting this Alzheimer's and Brain Awareness series. It's great to be partnering with people who share our vision of hope for the future for people who are affected by Alzheimer's and dementia now and maybe in the future. So I'm thrilled tonight to be having a conversation with Dr. Andrew Budson. Dr. Budson was educated at Harvard College and at Haverford College and Harvard Medical School. He is the Chief Cognitive Behavioral Neurology at the Veterans Affairs Boston Healthcare System. He's an Associate Director of the Boston University Alzheimer's Disease Research Center, Professor of Neurology at Boston University, and Lecturer in Neurology at Harvard Medical School. He's published over 150 papers and 9 books, including 6 Steps to Managing Alzheimer's Disease and Dementia, a guide for families, and 7 Steps for Managing Your Aging Memory, What's Normal, What's Not, and What to Do About It. I'm thrilled to have this conversation with Dr. Budson tonight. We're going to get to our questions in a second, but just a few housekeeping notes. Please, you'll find a lot of information and additional links in the chat, and we are planning to leave 20 to 25 minutes at the end for your questions. So please put those in the Q&A, and we'll get to as many of those as possible. And one final housekeeping note, because I know this will come up in the questions. We are recording tonight's program, if you didn't hear that, and we will send a recording of this program to everyone who registered sometime tomorrow. So thank you all for joining us, and again, welcome, Dr. Budson.
Thanks so much for having me.
So we're going to kick off this conversation, and would love to hear you talk a little bit to our audience about what's the difference between normal changes with cognition and the possibility of dementia. That's a question that comes to us all the time on the helpline, people wanting to know, should they be worried or not?
Sure. So as part of normal aging, there is typically 3 changes that occur. So one is that information might need to be repeated a couple of times until the healthy older adult has got it. Like, okay, now I got it in my noggin. The second is that when people are retrieving information, it might take a little bit longer for people to search through their memories and, oh, there it is, and find the information that they're looking for. And the third part of normal aging is that sometimes individuals may need a hint or a cue to retrieve the information and say, oh, that's right, that's the restaurant that we went to, last week. But importantly, in normal aging, as long as the information got into the memory stores, it should be able to be retrieved, even if it needs a hint or a cue. Now, I want to contrast that with the memory changes that we can see in Alzheimer's disease and related dementias. And in that situation, even when information is repeated a couple of times, even if you wait a bit of time or give a hint or a cue, the information cannot be retrieved. It essentially goes down into a hole and is just lost. And when information is lost like that, we call it rapid forgetting. And rapid forgetting is never normal. That's the sign that someone needs to go to their doctor or bring their loved one to the doctor to get it evaluated.
Thank you for that explanation. I think that's a big point of confusion. We all know people who are very worried the minute they forget something and wondering, how to make sense of that. The other really common question, this is probably the most common question people ask me when they know I work for the Alzheimer's Association, which is, what is the difference between Alzheimer's and dementia? And often that's followed up by, which one is worse? And I know,
Yeah.
I know. When you work in the field, it's hard not. Yeah. It's kind of a strange question. But anyway, could you explain that to people? Because I think that's often on people's minds.
Yes. So dementia is a general syndrome that simply means thinking and memory has deteriorated to the point that it interferes with day-to-day function. And Alzheimer's is one type or one kind or one cause of dementia. And let me give you a little analogy that I think will help. I think about this general concept of dementia, sort of like another general concept like a headache, right? And a headache can be from a lot of different causes, right? It could be like from muscle tension aches or a migraine headache, which aren't very serious, but it could also be from something that is very serious, such as a stroke or a brain tumor or something like that. And with dementia, it's the same way, so that there can be some causes of dementia that are completely treatable and curable, like a thyroid disorder or a vitamin deficiency. But then, there's some types of dementia that are caused by brain diseases like Alzheimer's, dementia with Lewy bodies, vascular dementia due to strokes, and there's many other types as well. So dementia is the general syndrome. Alzheimer's is simply one cause of it. So it's not that one is, worse or better than the other.
Yes, but that they are different concepts, definitely.
Absolutely.
Yeah. And I do think I'll just take a moment to highlight that while our name is the Alzheimer's Association, we do help families, we fund research, we advocate for policy for all different kinds of dementia. So I just don't want people to leave not knowing that point. So Dr. Budson, you mentioned that, the changes that we see, the dementia type changes we see that are related to Alzheimer's are a disease of the brain. Could you explain a little bit to our audience what it is that happens in the brain that causes these dementia symptoms to occur?
Sure. So we now have pretty good evidence that the first thing that happens is there's an accumulation of a protein called beta amyloid. This clusters and clumps together outside of the brain cells and gets bigger and bigger. And at some point, it gets big enough and it starts to cause an inflammatory reaction. So the body's immune system gets involved and it starts to disrupt the function of brain cells that are neighboring, that are next door to it. And then inside those brain cells, another process occurs where another protein called tau, T-A-U, gets loose, and the tau is very sticky, and it sticks to itself, and it forms these long chains, and the chains get all tangled up inside the cells. And once the tangles form inside the cells, it actually kills the cells. And that's what causes the trouble with thinking and memory in Alzheimer's disease.
And does that happen everywhere in the brain all at once, or does that happen in different parts of the brain to start?
Yeah, that's a very good question. In the classic case of Alzheimer's, which is the most common, it starts deep in the temporal lobes in a structure called the hippocampus and related structures right next to it. And these are structures that are involved in forming new memories. And this is why the classic individual with Alzheimer's will have trouble learning new information, often with remarkable preservation of earlier memories. So you mentioned that I work at the VA. So many of my veterans with Alzheimer's disease who are now in their 70s and 80s, they can tell me everything that happened when they were in the service, when they were in the war, it with great detail, but they can't tell me what they had for breakfast that morning. So when we're, worried about, the changes in memory that are related to Alzheimer's, it's typically remembering new information, which leads people to end up repeating the same question again and again and again because they don't remember the answer. They don't remember that they've asked it before. It leads to repeating the same stories to the same people again and again and again. And it can also lead to getting lost even on familiar routes and misplacing things in a way that's different from the way that they used to be able to remember things. People start to lose their cell phones, their wallets, important things they wouldn't normally lose.
Yeah, thank you for that explanation. Can you talk a little bit to, I'm sure that our audience has a much better understanding of how Alzheimer's affects memory. Can you talk a little bit to how, as this disease progresses, what are some other symptoms that people are often experiencing beyond memory?
Sure. So as the disorder sort of spreads to different parts of the brain, another very prominent symptom is word finding difficulty. People begin to have difficulty finding the right words. Families often get used to jumping in to helping out the word that they're searching for. And then as that language problem progresses, people can actually lose the meaning of the word. And once they lose the meaning of the word, they can have difficulty with comprehension, difficulty understanding. Another symptom that can happen is sometimes the individual can have difficulty recognizing people and recognizing faces. This can often be devastating for family members when their loved one doesn't seem to recognize them. Sometimes there can be a situation where they think it looks like the person, but they actually think it's like they've been replaced by an imposter, as strange as that sounds. That's not so uncommon. Another thing that can happen is people can have false or distorted memories. They may report things that either never happened or might have happened, but happened 30 years ago, but the individual saying it happened yesterday. And then other things that are very common is it becomes more and more difficult to do sort of complicated activities, even if they're not really related to memory per se.
Yeah.
Like people can have difficulty making coffee in the coffee maker. They can have difficulty, cooking a meal. They can have difficulty paying the bills, all sorts of things like that. And of course, there's much more, but that's a sample of some.
Yeah, thanks for giving us that idea, because I think sometimes there is this conception that Alzheimer's is all about memory. And that may be where it starts for most people in what we see, but certainly people who are living with Alzheimer's and their caregivers are dealing with more than memory.
Absolutely. And it can actually start in any of those ways that we just talked about. That's why when I talked about the memory, I talked about the classic case. Yeah,
exactly. So I'm rewinding a little bit to what we've kind of started talking about, which is, what's Alzheimer's and dementia, what happens in the brain. So kind of thinking about that, how did doctors like you figure out that, when someone's coming to you with these concerns, that this indeed is Alzheimer's or vascular dementia or whatever type of dementia it is?
Sure. Yeah. So I always begin by listening to the individual themselves, what changes they've noticed in their thinking and memory. But I also speak with family members or close friends with their permission as well, because of course it's difficult for the individual with memory problem to remember all the times that they're getting into trouble. So it really is helpful to have a friend or family member come with them to the appointment who can also describe things as well, and who can also help the individual remember all the things that were discussed in the appointment. After that, taking a history of that, I do all the usual things that a doctor would do, like make sure I know their other medical problems and their medications, et cetera, et cetera. And then I want to get a picture of the brain to make sure there hasn't been some abnormality that I can see right away, like there's no brain tumor, there's no big stroke, or something like that. And we'll do blood tests to taking some blood, usually from the arm, to make sure that there isn't a vitamin deficiency or a thyroid disorder or a chronic infection or something like that. And then we'll do some pencil and paper testing. And I will say the minimum pencil and paper testing that I would expect a doctor to do would take about 10-15 minutes, maybe doing a test called the Mini Mental State Examination or the Montreal Cognitive Assessment. These tests are sometimes called the MMSE or the MoCA. And many times we'll do a little bit longer testing. In my clinic, we do an additional hour's worth of testing with individuals. Neuropsychologists might do 2 or even 3 hours of testing with an individual, but the minimum would be 10-15 minute quick testing. And then I'll see them back in a month or two, and usually by the time I have all that information, between the history from the individual, from the family, the MRI or CAT scan of their brain, the blood tests, and the pencil and paper tests, I generally have enough information to be able to figure out, what I think the cause of the thinking and memory problems, whether it's Alzheimer's or a different disorder.
Thank you. And with that, like, at what point, I know a lot of people are hearing a lot more with treatments emerging about
Yeah.
testing that can be done. At what point might somebody be having a lumbar puncture, a PET scan, or something, some more advanced type of diagnostic screening?
Yeah, so that's a very good question. So it turns out that the medications that help to raise up a chemical in the brain called acetylcholine that have been around for a long time, since around 1997, this class of medications can work well for the top 3 causes of memory loss. They work well for Alzheimer's disease. They work well for dementia with Lewy bodies or Lewy body dementia, and they work well for vascular dementia. And so these are medications like donepezil, brand named Aricept, rivastigmine, brand name Exelon, and galantamine. So all of these medications, they can actually sort of turn the clock back on the memory loss by 6 to 12 months in these disorders. So if I'm seeing a patient and this is going to be the primary medication that I'm going to be prescribing for them, I've generally done as much workup as I need to do to figure out what the problem is and start to treat them. Now, there's a newer medication out there that some of you may have heard of. It's called lecanemab, a brand name Leqembi. And this is a medication that instead of raising up the level of a chemical in the brain, it actually works to remove those plaques that we were talking about earlier. So these plaques that are made up of amyloid. So we can now give a new treatment that's given by vein, given by an IV every other week. So it's a sort of a big production, but we can now do this every other week. And that removes the plaques from the brain, and that can actually slow down the ticking clock of Alzheimer's. So instead of turning the clock back, but then the clock is ticking down at the same rate, this lecanemab, it doesn't turn the clock back, but it slows down the clock so people don't progress as quickly. And because this medication is sort of a big deal, it's a big production, people have to come in every other week into the infusion suite to get an IV infusion. We would only give it if we really knew with 100% certainty that they had Alzheimer's, because it only works for Alzheimer's, doesn't work for dementia with Lewy bodies, doesn't work for vascular dementia. So in those situations, I would go ahead and get the amyloid PET scan, or I would do a lumbar puncture to look and confirm that they have Alzheimer's disease. Those are the 2 ways that people can confirm that they have Alzheimer's. So I do want to stress, it's not necessary for everyone, but it is necessary to consider this new medication. And let me just continue for 1 minute, Nicole, to just sort of say, like, so why wouldn't everybody get this medication? Well, it turns out that this is a medication that works well, number one, if people are very mild, okay, just have the earliest symptoms. And we spoke earlier about dementia, which is when there's a decline in thinking and memory that affects day-to-day function. So there's actually an earlier stage called mild cognitive impairment. And this is when someone's concerned about the memory. The concern is confirmed when they do pencil and paper testing, but their day-to-day function is still normal. So in this situation, the thinking and memory problems don't yet interfere with day-to-day function. And what the studies have shown is that this new medicine, lecanemab, it works well for people in this mild cognitive impairment stage, or just the earliest or mildest stages of dementia, when people have trouble doing complicated things like doing their finances, paying taxes, preparing meals. but can still do all of their basic daily activities just fine, like eating, dressing, using the toilet, things like that. And so people with very mild disease would be candidates for lecanemab. People who don't have major other medical problems may be good candidates. And people who are not on blood thinners other than aspirin and aspirin-like drugs are generally good candidates. And believe it or not, there's even more criteria that have to be done. We need to look carefully at the MRI scan of the brain. People, in fact, have to be able to get MRI scans. If someone isn't able to get an MRI scan for whatever reason, we can't put them on this medicine because we need to monitor it with MRI scans. So that's probably more information than you wanted to know, but those are the times when I would use some of the advanced tests and a little bit about the treatments, which really is what pushes me to use the advanced tests.
Well, thank you for that. I'm glad you did dive into that, because I have to say that was one question we got emailed in advance to us, was around Leqembi and some detail around Leqembi as well. And that hit the points that they brought up, definitely. I mean, it's a really it's a really exciting time. Those of us in this field have waited a long time to have a medication that modifies this disease, and it's exciting to have some other medications in the pipeline as well right now.
And I'll very proudly say at VA Boston, we're currently infusing 20 patients with lecanemab. We were first in the nation in VA hospitals to do it. And if there's more questions from the audience, I'm very happy to go into more details.
Well, that is very exciting news. And I think that, and talking about, the hope of this new treatment, as well as treatments that we have, medications that we have had that tend to work better when people are in the earlier stages, it really does highlight the importance of people paying attention to these changes in their memory and talking to their doctor, and not avoiding those questions, because you can miss that really important window.
Absolutely. And I would just like to highlight that the reason I wrote with my colleague, Dr. Maureen O'Connor, the 7 Steps to Managing Your Aging Memory book, is that if you go to your doctor because you're concerned about your memory, and your doctor says, "Oh, don't worry about that. All my patients your age are complaining about memory problems. It's fine. Don't worry about it." But you're worried about it after listening to this discussion, you go find another doctor, find a specialist, or go back to your doctor and say, you know what? I don't care that all the other individuals are complaining about their memory. I'm concerned something's wrong. I want to see someone who can really evaluate me. I've heard too many stories of people, who come to see me 3 years later and said, I told my doctor this 3 years ago and he told me not to worry about it. So don't accept the doctor if you disagree with them.
And that is a great point to bring up. And I'm sure you hear it as a physician, and we hear that on the helpline all the time with people that are still worried. And we always do encourage them that, that you know yourself well,
Exactly.
and advocate for yourself. And if you need to, find another doctor.
That's right. That's exactly.
But because it's really important, because that still, unfortunately, is a response that people hear from time to time. So kind of speaking of that diagnosis early, I guess related to that, I'm sure we have people in our audience who are here because they have a family history of Alzheimer's disease, and maybe that's made them at a heightened awareness for symptoms they might be experiencing, or just knowing, I need to make sure I know about this. Could you speak to what the risk factors are for developing Alzheimer's disease? Because I think there's some misconceptions around that as well.
Sure. So, I'll talk briefly about the risk factors, but then I want to talk more, with your permission, about what all these individuals who are worried about it can do to reduce their risk.
That's perfect. It would be my next question anyway.
Okay,
so,
okay.
Yes.
Because a lot of the risks are almost the reverse of what you can do to help. So, for example, let's talk about the things first you can't do anything about, okay? The number one risk factor for Alzheimer's is old age. So we want you to live to old age, but living longer, there is an increase in risk as people get older until you reach 100. And people who are older than 100, the risk actually drops off. So just keep going, keep going. Another risk that is, I think, is family history. Okay. And I'm sure, everybody's like, yeah, I know that. I'm worried about it. So it does increase your risk, but I will tell you that half the people with Alzheimer's do have a family history, but the other half don't. So everyone is at risk for Alzheimer's disease, even if you don't have a family history. All right, now let's dive into some of the risk factors people can do things about. So I think and I'm going to start with the most succinct way that I can put this, which was told to me by a colleague, and I think he's absolutely right. You want to stay as healthy as you can, okay? That is like, if you want to just come away from this seminar with a single thing, try to stay as healthy as you can. So what does that mean? Well, number one, it means take care of all your medical health needs. So you want to take care of your blood pressure if you have it, your high cholesterol if you have it, diabetes if you have it, things like that. If you can take care of those things with medications, that's great. If you are someone, and speaking with your doctor, that you think you can take care of those things with diet, exercise, weight loss, do that. The studies actually show that your risk will be even lower if you can take care of high blood pressure, high cholesterol, and diabetes by making lifestyle modifications. So let's dive into the lifestyle a little bit. So physical activity is probably the most important thing. And there are now good studies to show, number one, that you need to do at least moderate exercise, which means cardiovascular exercise, gets your heart beating quickly, gets you breathing heavily, at least 30 minutes a day, 5 days a week. And, if your bones and your joints and your other parts of your bodies allow you to do a little bit more, do more. Now, if you're somebody who has never exercised in your life, or you've never exercised as much in your life, and you're not sure what's right to do, please, please, please speak with your doctor to make sure that your heart and lungs and bones and joints are ready for this. So before you start, running out the door and exercising more after this webinar. But that's really the most important thing. So at least moderate level of vigorous activity. But in addition, there's independent studies to show that you should not be sedentary for the rest of the day. Don't simply sit in a chair all day long. If you're on a call that allows it, get up and walk around your house, walk around the neighborhood, even just walk around the room. It's important to not be sedentary. Now let's talk about foods. In my opinion, there's two main factors for foods that have become very, very clear. The one is we want you to eat a Mediterranean menu of foods. So this includes fish, olive oil, avocados, fruits and vegetables, nuts and beans, and whole grains. Okay, that's a basic Mediterranean menu. Is chicken okay? Yes, chicken is okay. It's not classically in the Mediterranean menu, but it's perfectly fine. The other thing that we've learned is that so-called ultra-processed foods are also bad for you. So whole foods are good, ultra-processed foods are bad. And so this includes things like sugar sodas and diet sodas, because it's basically, filtrates of either sugar or sugar substitutes that trick your body too much into thinking it's getting sugar. It's things like hot dogs and bologna, processed meats. It's things like Twinkies and other, snack cakes. And it's also things like chips, like, Pringles and Cheetos and all sorts of other things like that. So those are the important things in terms of foods. And then the last sort of category are sort of other lifestyle factors. So it turns out that being socially active turns out to be really important. There's actually good evidence that that is a large part of our brain, is devoted to having good social interactions. And it's really important now that hopefully the pandemic is done, that people are getting out and spending time, with person-to-person interaction is really important. It's important to, continue to learn things, continue to exercise your brain, learning new things throughout life. And it's even important to have a positive mental attitude. This has been shown in study after study, and we think it works for all the obvious reasons. If you have a positive attitude, you're more likely to be social and outgoing. If you have a positive attitude, you're more likely to take care of yourself, eat right, and exercise. So that's a little bit about some of the risks, which is if you don't do those things, and the benefits if you do those things.
Thank you. And I saw that my friend Norma put 10 healthy habits for the brain in the chat, which hits on everything that Dr. Budson just talked to, brings up the issue of sleep as well.
Oh, sleep. Yes.
And preventing
Important.
head injury and things like that. And I will say,
Totally.
we're going to have on our Brain Health Tuesdays, we talked about cooking last week, and we posted that, not that last week, 2 days ago, and cooked a very healthy recipe, all with whole type foods in it that he just talked about, and talked about ways to make that affordable for people as well.
Yes,
and we're going to be having programs on sleep, brain, head injury prevention, and ways to incorporate exercise into your everyday life. And I can see, and Norma's putting in the chat how to get more information about those programs, because there is a lot of promising steps that people can take. And there's a building body of evidence that these changes make a real difference in either reducing your risk of developing Alzheimer's or delaying its onset.
Absolutely.
Which of course is good news for all of us. I'm going to take I have my questions on my other screen. I'm going to take a quick glance and we'll start taking some of the questions from the audience, because I can see some good ones emerging, but I'm going to take a look here. And here's one. You referenced this a little bit, but could you just talk a little bit more to mild cognitive impairment and whether that always leads to a diagnosis of dementia or not? What's the prognosis for somebody with that diagnosis?
Good question. So overall, it's approximately half of people who are meeting these criteria of mild cognitive impairment, where they or their loved ones are concerned that there's a problem. They have trouble with the pencil and paper test, but their day-to-day function is normal. So about half of them do go on to develop either Alzheimer's or a related disorder, but the other half don't. Sometimes it could be depression, could be side effects of a medication. They're recovering from a recent surgery that they had poor sleep the night before. They were under the weather, all sorts of things like that.
Thank you for that explanation. Related to you saying that depression sometimes causes those symptoms, we got this question a couple of times in the Q&A, which was about the issue, can high levels of stress cause some of the symptoms of Alzheimer's disease?
So what I would say is, I think of there being two different types of stress. There's the type of stress that most of us experience day to day. There's the stress that we go through at work. There's the stress if we're a caregiver and caring for our loved one with dementia. There's the stress if, you're going through, something like, a divorce or something like that, right? There's those types of stress. And those types of stress will make one distracted and have difficulty concentrating. And because of that, it may be hard to sort of learn that information, that new information when someone's telling you something, because number one, your brain is not functioning as well because it's distracted about this. And number two, you may be sort of actually thinking about something else. So there can be both brain issues when there's high levels of cortisol and epinephrine, when you're feeling stressed, that make it more difficult to get information into your memory stores. And it also can be difficult to pull it out. But if it's just due to stress, there should not be rapid forgetting. So if somebody reminds you, oh, you remember that was the movie that we saw, you should say, oh, that's right, I remember it. Okay. So that's can be one of the differences. So stress is sort of like normal aging, but worse. Okay. But you should be able to tell the difference. I can tell the difference. A neuropsychologist can tell the difference. That can be sorted out. Then there's one other type of stress, which is really horrific stress, like victims of, physical or sexual abuse that, may be prolonged, prisoners of war, people who are tortured, those types of things, not always, thank God, but sometimes can actually cause changes in brain structures, including the hippocampus, that can sort of permanently damage the brain. But luckily, that type of stress is not all that common.
Thank you for that explanation. Another question that's come up several times in the Q&A is around diagnostics, and in particular, what's the progress towards having a blood test to determine if people have Alzheimer's?
It is so exciting. So I will succinctly say that right now, today, I don't recommend any of the current available blood tests because they're not quite ready enough. The false positives and false negatives, meaning they may say you have it when you don't, or they may say you don't have it when you do. It's not quite good enough that I don't recommend it. But very soon, within 1 to 2 years, these new tests that are currently under research will be available. And so I think very soon, we're not going to need those amyloid PET scans or doing a spinal tap, a lumbar puncture to diagnose Alzheimer's. We'll be able to do it with a blood test within 1 to 2 years.
And related to that, we have a question. I think this is what the person in the Q&A is asking, is around the fact that, before we see symptoms, there are changes that are happening in the brain that you described. And so I don't know if you could talk a little bit to that, like in that preclinical stage, but and then I would say, and would a blood test, the ones we know of, would they detect Alzheimer's before we see symptoms?
Yeah, sure. So the first thing to say is right now, okay, June 6th, 2024, we don't have knowledge of what to do if somebody has amyloid plaques in their brain, with or without tau tangles, and they have no symptoms whatsoever. However, there's very exciting, very good studies that are being done to find out if we treat with lecanemab and medications like lecanemab to remove the plaques before people develop symptoms, will this help? And I think so. It's my best guess. And I can even imagine a situation in the future where everyone will get a screening blood test, when they're in their 50s to determine if they're at risk of developing, Alzheimer's disease. Because to answer that question specifically, the blood test will pick up if there's Alzheimer's plaques in the brain, even in a person that doesn't have any symptoms currently. So I can see in the future, just like, we get screened for colon cancer and women get screened, for breast cancer with mammograms, and men get screened at least sometimes for prostate cancer, that there'll be a screening blood test for Alzheimer's. And the future is, Mrs. Jones, the bad news is it looks like you have Alzheimer's plaques in the brain. The good news is we'll give you this medication and we'll remove all the plaques before they cause any damage to your brain. That is the future, in my opinion.
But we're not, just to clarify, but we're not quite there
We
yet.
are not there yet. Absolutely. No, as I said in the beginning, in June 6th, 2024,
Yeah.
you know, I would not recommend that anyone who has no symptoms, I don't recommend those individuals get any type of testing whatsoever, because there's nothing known to do about that.
So we did get a few more detailed questions about Leqembi that I wanted to put throw your way. So people, we have some questions around how long people would undergo this treatment, and do we know how much of the plaque gets removed? Like how effective the Leqembi is? What do studies show?
Yeah, it's extremely effective. Some people clear the majority of the plaques in 6 months, some people in 12 months, some people in 18 months. Most people by 18 months have cleared the majority of the plaques. I was recently with a panel of experts, and no one knows the right answer as to how long you should treat with lecanemab. Some people say, well, the study was, so Leqembi is the brand name, lecanemab is the generic name, same medicine. The study was 18 months long. So some people say, well, we should do it for 18 months and then we should stop, because that's what the study did. Some people say, well, we should monitor with amyloid PET scans or some other way. It may be blood tests in the future. And once the plaques are removed, then we should stop it. And there's good rationale for that, although we might want to monitor, you know, perhaps 6 months or yearly to make sure they're not coming back. So people are not exactly sure in terms of how long. Our approach at the VA is that we are going to be monitoring with amyloid PET scans approximately every 6 months once people start it. And once they have cleared it, then we'll have a discussion with them about what do they want to do. Because ultimately, the whole purpose of treating Alzheimer's disease is to improve people's lives. And, you know, not everybody wants to go get an IV infusion for an hour every other week. You know, it's one thing to sort of say, well, I'll do this for a year or two, just like, you know, if you have cancer, you may have treatments that may last for a year or two. But it's another thing to say, for the next 10 years, for the next 20 years, like, does this make any sense? So, you know, so I want to work individually with each patient, talk about what's known, what's not known, you know, what are the risks of going off it? What are the benefits, you know, staying on it? Is it worth it or not? And what fits with their lifestyle? And I don't think it's going to be the same answer for every individual.
And I think we've had a great explanation of the treatments that have been approved by the FDA, kind of how they work, what they are. But people are, I know, I'm sure that my social media knows I work for the Alzheimer's Association, so I get ads that are related to Alzheimer's, and people here are too. Can you speak to, you know, what we hear in social media and on TV about things that, you know, like natural supplements that say they will, you know, treat Alzheimer's or prevent the risk? Could you just speak to that, how people should approach those?
And am I allowed to say them by name?
Go right ahead.
So as Norma is putting in the chat right there, you know, Prevagen, I want to say very clearly, there's no evidence it works, okay? No evidence it works whatsoever. They have great ads, I agree, they have wonderful ads, but it just doesn't work. And it's a great way to waste your money. So I really would recommend that people not throw their money away on Prevagen or any other of these sort of supplements and things like that. Like, it would be great, right, if we could just sort of take a pill and the stuff would all go away. You know, but we're not there yet. There aren't any of these supplements that would help. There are no vitamins that help unless you have a vitamin deficiency. And, that's one of the first things your doctor will do, just like I had talked about earlier. When you're being evaluated for memory problems, they'll test you for, common vitamin deficiencies like B12, vitamin D, maybe vitamin B1, thiamine, depending on the situation. And if you're deficient, then, we'll give you medications or the vitamins to get you back to a normal level. But there's no vitamins or supplements other than that to get you, that will help.
Yeah. And I will say, when we get these questions a lot, as you can imagine, at the association, whether we're out talking in the community or in the helpline, and we, strongly urge people, whenever you consider things, even if they are natural, you should talk to your doctor about them.
Absolutely, because sometimes they'll have side effects with other medicines that you're taking.
Yeah. So I think there's sometimes a misconception that if it's natural, there's no harm. Like, why wouldn't I throw everything at the wall at this? But unfortunately, there can be some risks associated with things that are even labeled as natural. So definitely work with your doctor and what that plan is. We also have a few questions. We've talked a lot about diagnosis and the blood test, but also we've had some questions around genetics and Alzheimer's, and whether there has been a gene that's discovered to cause Alzheimer's disease.
Yeah, so there are the common genes that we know about have an increased risk of Alzheimer's disease. And this is called an ApoE allele. And everybody has two alleles. They have one they inherited from their mother and one they inherited from their father. Most Caucasians have the E3 allele. And the reason I say Caucasians is we've found through good research, now that we're doing studies that have a more diverse population, that we don't know as much information about people who are of other genetic backgrounds, of other races. And that's actually one of the reasons I'm going to put a pitch right here. We really need everyone to participate in research studies so we can get this type of information. Whatever shade of color of your skin, wherever you come from, where your parents are from, we really want you to participate in research. It's vitally important. So the E3 alleles, the E3 sort of variants, are the most common. And if we think of that as the reference range for Alzheimer's, people who have one E4 are at increased risk. People who have two E4s are at even higher risk. There was a recent study that came out that said, if you have two E4s, you're going to develop Alzheimer's disease. And I can say I disagree with that statement. I think there is actually very good evidence that even people who have two E4 alleles can reduce their risk of Alzheimer's such that they may never get it, even if they live, to age 100, by doing all of the good, healthy lifestyle things that we've talked about. So those are the common genetic tests. And we don't typically get them because for an individual person who's sitting in my office, they may have that gene, they may not have that gene. It doesn't correlate one-to-one. As I said earlier, half the people with Alzheimer's have a family history, but the other half don't. Yeah. And there's plenty of people with these E4 genes that never develop it. The reason we do get it is it actually changes your risk of side effects from lecanemab. So we've started to get it in people who are interested in lecanemab and would otherwise be eligible for lecanemab. The last thing I'll say is in some families, there is a stronger genetic mutation that is either the gene that codes for the amyloid protein called the Alzheimer's precursor protein, or it codes for one of the enzymes that cuts that Alzheimer's precursor protein into, or amyloid precursor protein into amyloid. And those families tend to get the disease when they're quite young. And I mean like 40s and 50s. So that's very rare and a different sort of situation.
Yeah. And I think that in this area of genetics is another huge area of research in the world of Alzheimer's disease. Since there is such a family history, there's a lot more to learn in that area, definitely. We have we have time for, I think, two. I don't want to say they're short questions, but they're more narrow questions, let's just say. So one question we have, and this is an interesting one, I don't think I've been asked this before, but is there pain associated with the development of plaques and tangles in the brain?
No, thank God there is not. It's probably because the brain itself, nerve cells, brain cells, there's no pain receptors in the brain. The blood vessels, yes, that's like what migraines are, is felt to be blood vessels, but not the actual neurons, not the actual brain cells.
And another question here is around the role of alcohol intake, and this question seems like kind of excessive alcohol intake on the risk of developing Alzheimer's disease.
Okay, thank you for that. So I want to first say that, you know, I have a glass of wine with dinner on occasion, or I go to a ball game, I'll have a beer along with my healthy peanuts that I'll eat. And the studies suggest that, you know, having one alcoholic beverage a day, which means, you know, a 12-ounce beer, a 6-ounce glass of wine, or a 1 ounce of hard liquor, whether it's mixed in a drink or not, you know, that seems to be okay. That seems to not increase your risk of Alzheimer's or related dementias. We used to think that having one alcoholic beverage is helpful. We now don't believe that. It seems like, you know, the honest truth is all alcohol is actually bad for you. Okay. So I wanted to start off saying, you know, I think, you know, people don't have to be a saint. You know, you can have a Twinkie once in a while, and you can have a glass of wine or a beer or whatever. But you want the true knowledge. The true knowledge is all alcohol is bad for you, and all Twinkies too.
Yeah. Thank you for that explanation. There has been a lot of confusing information about that issue over the years. Yeah. So thank you so much for getting to all these questions. We had a lot of variety of questions that we were able to discuss, and I really do appreciate that. I think for my final question, I would just ask, you know, what in your work, whether it's research or working with patients, what's your source of hope in working in the Alzheimer's field right now?
Yeah, I mean, I think, you know, the biggest hope that I have is, you know, I'm working with many trainees. I'm working with medical students and interns and residents and cognitive neurology fellows. I'm working with research assistants and college students and graduate students and postdoctoral fellows that are all interested in this field. You know, the clinical folks are working to care for people in this field, and those in the research world, you know, they want to achieve your vision, Nicole, of a world without Alzheimer's disease. And so I'm very hopeful for the future because of all the young people who want to be clinicians and researchers to help fight this disease and care for those who do get it.
Yes, thank you. I find that very hopeful as well. And we're not going to get anywhere unless we continue to have more people interested in this research. And it's wonderful to work for an organization that sees the importance of funding those new researchers so that they are able to tackle that research. So thank you everyone for these questions. I know we didn't get to everybody's questions, and we had a lot of action in the chat too. So I want to assure you that our 24/7 helpline, which Norma has put in the chat a couple of times, is eager to answer any questions that you have. You can call it. You can go to the website and ask a question through live chat if you would like. They would love to hear from you for any issues related to this or other things related to Alzheimer's and dementia, whether you're concerned because things are beginning or because you're caring for someone that's in the later stages, we are definitely there for you. We hope to see many of you at other programs that we have. We will send out a recording of this program at some point tomorrow. Feel free to watch it again, and also feel free to share it with others who would like to have that information. Thank you again to AARP for co-sponsoring. Thanks for my colleagues, Tim, Melissa, and Norma for working tonight and helping out behind the scenes. And of course, thank you, Dr. Budson, for sharing your experience and your knowledge and your optimism with us.
Absolutely.
Thank you so much.
So, thanks.
Have a great night, everyone.
Yeah, thanks for inviting me.
Bye-bye.